Most of our health happens outside a doctor's office, in neighborhoods, in workplaces, in community centers. So just as important are the steps we can take to engage older people as we do this critical work, involving them in the design, execution, and leadership of programs for seniors, and refuting any notion that as people age, they have less to contribute or become helpless. Our growing population of older people is also increasingly diverse. So respecting this diversity is key to maintaining social connections, reducing isolation, and increasing people's choices. Ultimately, what drives our approach is a philosophy that says simply, nothing about them without them. And you can see it in successful initiatives like Stanford University's Chronic Disease Self-Management Program, built on more than 2 decades of federal research. The program recognizes that older people with chronic diseases should be more than just recipients of care. They should be key decision makers in their own treatment. So through workshops in community settings like senior centers, libraries, and at faith-based organizations, older people with a wide array of conditions come together to learn, to share, and to build the skills they need to manage and improve their own health, from exercise and nutrition to stress management and communicating with their healthcare providers. Now at HHS, we've invested $27 million in grants to help communities implement these proven approaches. The evidence shows that this program not only improves patients' abilities to manage their own health, it's improved health outcomes and even reduced healthcare costs. So it's no wonder that the Stanford program is now available in at least 15 countries around the globe. What this kind of program tells us is that keeping older people healthy yields enormous dividends. When more people can participate more fully and contribute to society, everyone benefits. And this is where we have an important opportunity to work together, to share our best ideas and tools to keep populations as healthy, productive, and engaged as possible.
I think we need to embrace self-management as an essential component of a broader healthy aging agenda. And we need to understand that the knowledge and the skills for self-management are not simply delivered or taught, but rather they are developed through full participation of older adults in creating and implementing practical, visible, also evidence-based solutions and supports for their own individual aging and for population aging more generally. While some of the components of a broad healthy aging agenda, such as we have heard about today, will be shaped in the meeting rooms of national governments here and everywhere, and others will be designed by medical professionals and offered in healthcare settings, we must be certain that older people are fully engaged in this process. And how do we connect our work to this picture and to make sure that the people in Robert's neighborhood and in neighborhoods all over the United States, all over the Western Hemisphere, all over the world, have an opportunity to grasp healthy aging, at least in this programmatic context. For us, the principles of healthy aging have been about 5 core things. First, to focus on preventable risk factors, such as Linda spoke about, for chronic health problems, for falls, and for depression. Second, to start with proven programs and the evidence about what will work and will make a difference, and to keep conducting research so that we learn more about that. Third, to make sure that the programs that we're engaged in and the concepts that we're working from emphasize self-management and self-determination. Fourth, that these programs and these approaches address health disparities, recognize the diversity of our populations, and combat ageist ideas. And finally, and equally important with the others, that whenever possible, The approach to healthy aging is grounded in the communities where people live, that the first choice and the first access point should be as close to where people live as possible, and what cannot be done there then gravitates up to more sophisticated institutional settings, but that as professionals we do not try to own this process. So how has this been done here in the United States and in a couple of other places that I know of in other countries? And there's really been kind of four features that I think have been essential to our success, which I will describe in this effort. One is there has been an amazing, sustained national, state, and local collaboration. At the national level in the United States, the U.S. Administration on Aging, the entire Department of Health and Human Services, Centers for Disease Control and Prevention, many other federal partners have made a commitment to healthy aging and to having access to evidence-based health promotion disease prevention programs throughout this country. They've committed to it, they've funded it, and they've collaborated on it. Major philanthropies, such as Atlantic Philanthropies, regional philanthropies, have also made substantial investments, including the program that Martha, who was introduced earlier, is leading in South Florida. Researchers are doing studies all the time, as well as taking the interventions that they have shown to work. Linda was talking about Experience Corps. There's the work at Stanford. There's been work at the University of Washington, University of Illinois, Chicago, and where these scientists have made the commitment to stick with their work through massive implementation challenges. So it's not just a matter of getting those studies published. It is also a matter of thinking about how you can scale those interventions and work with community partners to make it happen. And then there has been a very critical role, I think, for NGOs, such as the National Council on Aging, to convene many of these sectors together. It is through this collaboration, through funding, through technical assistance, through hands-on consultation, training, and tailoring that we have been able to engage local governments, regional governments, local social service, public health, healthcare organization, and even Robert himself in getting this work done across the nation. In frontline communities, this work has been embraced certainly by what we call in the United States the Aging Network, organizations that serve older adults, by the public health system, by the community health system and many healthcare providers, by mental health, by faith-based organizations, by community organizations, community centers, by YMCAs, by housing. One of my favorites is that the jails and the prison systems in the United States are embracing this as their populations are increasingly growing old, and they are offering evidence-based health programs in those settings, our educational institutions, and our employers. One of the things that another core feature besides the collaborative part is the access to multiple kinds of evidence-based programs. We've talked a lot about the Stanford program. It is perhaps the best known. It's been done around the world. But there are many others, and what we have found is that it's the availability of multiple programs and the community getting engaged around multiple programs that really helps to sort of gin up the impact. That gives older people a chance to choose what they're interested in, and organizations can contribute in ways that are unique to their own skills. So we have group-based programs, all evidence-based for physical activity, for preventing falls, for managing chronic conditions. We have one-on-one interventions that can take place in the home or in a community setting for managing depression symptoms, for helping to create behavior change, for managing substance abuse, and for other risk factors. Across all of these programs, there's a set of characteristics that will make them work, and we've gotten pretty good at knowing what those are. Certainly, the science has to be good. They have to have demonstrated health outcomes. that are replicable across a variety of populations. It can be reducing falls, it could be increasing physical activity, it can be improved self-efficacy, reductions in pain, reductions in fatigue, but those have to be known, and you need to be focusing the programs on reproducing those results. They have to be empowering, they have to increase skills and confidence. Again, they have to be suitable for many populations and suitable for many settings. And there have to be trainings and toolkits that allow for scalability. These cannot simply go from a journal article to national dissemination. There has to be a tremendous research translation piece in the middle of all this work. So to summarize around what this has meant for in the last 10 years in the United States, I began some of this work with a whole bunch of colleagues in early 2000. In 2003, the U.S. Administration on Aging invested in 14 communities, sort of cities, to do one pilot project in each of those places. We began gathering serious data on this work in 2006 as the funding expanded to 24 states. And just to give you an idea about what has happened since 2006, in our databases, which we believe capture about 50 to 60% of the total activity around these evidence-based programs, in 2006, there were 6,800 participants, not bad. But by 2011, in that year, 68,000 people, a tenfold increase in 5 years, had participated in these programs, bringing the total to well over 170,000 people in that 5-year span. Over 60% of these people are 70 years of age or older, so this is not about playing golf at the age of 62. About 40% are members of racial or ethnic minority groups, and we have gone from the 2003 12 communities to having active programming in all but 2 of the states, and we think they're going to come on shortly. Over 900 organizations have built the infrastructure to manage this kind of programming, and they have offered these programs in over 5,000 locations, including Robert's Garage. They have done this with fidelity, with quality assurance, with important training and monitoring of the people who facilitate these workshops. They have engaged older adults in the facilitation of the work, in the design of the work, in the operation of the work, and in being national spokespeople for this work. At the national level, we have embedded in federal policy and the Affordable Care Act, in funding in aging and public health, in funding for state Medicaid programs, this concept of self-management and an evidence-based approach. The Department of Health and Human Services has established a multiple chronic conditions initiative with 4 goals, and one of the goals is around promoting self-management. There is at NCOA now a public-private partnership called the Self-Management Alliance to continue to expand this work. So 170,000 people in 5 years is great. We have 40 million older adults in this country. We clearly have a long ways to go. I think we have learned how to do this work, how to draw the connections between very high-level concepts and what goes on in Robert's Garage. But we still have much to learn about how do you engage the healthcare community in this work? How do you help people see what this can mean in their lives? How do you guarantee quality? How do you guarantee fidelity? How do you secure sustainable financing for health that is delivered in community settings and not in medical settings? But our bottom line is that this is a very viable approach to being part of a much broader agenda around healthy aging. We think these structures can be built and that the impact can be felt in very human ways among older people. Thank you.